So hi guys, good evening. Am I audible? Okay. So I'm Maria Martin. I'm a pharmacist. Currently I'm working as a senior faculty in Pharma International Institute. So today I'm conducting a live YouTube demo session on a very simple, very interesting, very important topic, which is pharmacokinetics and biopharmaceutics. So let's start. Pharmacokinetics and biopharmaceutics. So before moving into this pharmacokinetics and biopharmaceutics, what is pharmacology? So word pharmacology is, I'll first split this pharmacology into two. Pharmacon means it's drug, and logy, which is mean a science. So it is a drug science or a study of drug. Now, the two very important branches of pharmacology are pharmacokinetics and pharmacodynamics. So what is pharmacokinetics? Pharmacokinetics means, pharmacon means, as I've mentioned earlier, it is drug. And what is kinesis? Kinesis simply means it is the movement of drug. That means when we take a drug orally, the action of body on the drug is defined by pharmacokinetics. So there are 4 parameters in pharmacokinetics, which are ADME, that is absorption, distribution, metabolism, and excretion. So that is pharmacokinetics. Now, moving to pharmacodynamics. Pharmacodynamics means after the ADME process, how the drug acts in the body. So it can be a drug receptor binding, it can be the mechanism of action, it can be the therapeutic interaction, and even the side effect. So it is simply what the drug does to the body. That is pharmacodynamics. Next. So these two are the important branches of pharmacology. So in this session, we normally see the pharmacokinetics and one more topic, which is biopharmaceutics. Now, what is biopharmaceutics? See, biopharmaceutics means the physical, chemical properties of the drug, its dosage form, the route of administration that affects the ADME process, or the drug's formulation, its bioavailability, and the therapeutic effectiveness that depends on ADME process, absorption, distribution, metabolism, and excretion. Now, ADME, first is absorption. So I'll just give you a brief explanation on what is an ADME process. So when we take our drug orally, as such, it is not getting into the body. So what is absorption? When we take our drug orally, the movement of drug from the site of administration to the bloodstream, only to the bloodstream. That is known as absorption. Absorption. Now, what is distribution? The second process, what is distribution? The movement of drug from the plasma or the systemic circulation or the bloodstream to the tissues or the organs. That is known as distribution. So I can say this distribution is a reversible process, because after getting distributed, after metabolism, it should get excreted out. So for excretion, this distributed drug should come back into the bloodstream to get excreted out. Otherwise, it will cause accumulation and toxicity. So for excretion, it should undergo metabolism. Now, what is this metabolism? Metabolism means it is the conversion of a lipophilic drug to hydrophilic drug. Why it is the conversion of lipophilic to hydrophilic form? Because for a drug to get absorbed, for a drug to get distributed, the very important criteria is that it should be lipophilic in nature or lipid soluble, because the cell membrane is made up of lipid bilayer. So for excretion, we should convert this lipophilic drug to hydrophilic form. What is this hydrophilicity? Hydrophilicity means water loving. So it should easily get dissolved in the urine to get excreted. So that is simply the ADME process. Now we can see each in detail. So absorption, it is the movement of drug from the site of administration to the bloodstream, not to the tissue or to the organ, it is to the bloodstream. Next, distribution, it is, as I've mentioned, it is a reversible process because the distributed drug should come back to the bloodstream and should get excreted out. Metabolism, it is otherwise known as biotransformation. That is the conversion of a lipophilic drug to hydrophilic drug. Now, excretion. What is excretion? It is simply the removal of drug from the body through urine, bile, or feces. Next, absorption. First, we can move to ADME, which is the A, which is absorption. So, absorption is the measure of how fast and effectively a drug can enter the systemic circulation or the bloodstream. There are many factors that affect this absorption process. One is solubility, size, pH, concentration gradient, route of administration. Of course, solubility means, just now I have told you, the drug should be enough lipophilic so that it can easily diffuse through the cell membrane and get absorbed. And size, yeah, the size should be very small for easy absorption. pH in detail, I will explain in the coming slides. Concentration gradient and route of administration, that is also very important. And in case of an IV administered drug, why this route of administration is important in case of absorption? See, for an orally taken drug, yes, there is an absorption factor. But in case when we are giving the drug as IV infusion or an IV administered bolus drug, what about this absorption factor? Is there an absorption? No, because we are directly injecting the drug into the bloodstream. Okay, so there is no absorption factor there. Now, so before this absorption, okay, before this term absorption, this drug, the orally administered drug, should undergo 3 Ds. First is disintegration, dissolution, and diffusion. Because when we give a drug, an oral drug, as a whole, it cannot enter the bloodstream. So for that, it should undergo size reduction. That means it should convert to small granules. That is known as this disintegration process. And after disintegration, it will not directly go to the diffusion. Before that, for easy diffusion, it should get converted to a solution form. That means these granules should get dissolved in the GI fluid. That is known as dissolution. Now, after dissolution, after converting that to a solution form, now it will slowly diffuse across the cell membrane and get absorbed. So for an absorption, the drug should undergo 3 Ds, which are they? Disintegration, dissolution, and diffusion. Yes. So first is disintegration. What is disintegration? Disintegration refers to the mechanical breakup of compressed tablets into small granules so that it can easily get dissolved in the GI fluid. Next is dissolution. It is the process simply, it is just the solubility of the granules in the GI fluid. And for a drug granule to get solubilized in the GI fluid, it should be hydrophilic. So when we formulate a drug, it should be both hydrophilic as well as lipophilic. That means when we formulate a drug, it should contain both hydrophilic group as well as lipophilic group. Because for dissolution, the drug should be hydrophilic in nature. The drug should possess some hydrophilicity, water-loving nature. Because as you all know, GI fluid is like hydrophilic. So for a drug to dissolve in the GI fluid, it should be hydrophilic. Now, lipophilicity, if the drug is more of lipophilic functional group, the dissolution process will take time. Crystalline form, as you all know, crystalline form will take time to get dissolved in the fluid. Particle size, lesser the particle size, when we break down the particle, like the drug into smaller particles, fine granules, we are increasing the surface area. So more the surface area, more will be the dissolution. Next, the rate of dissolution. What is this rate? So any process, it can be a dissolution, it can be a disintegration, it can be a diffusion, whatever it is. A rate means a time will be mentioned there. That means a rate of dissolution means how much amount of drug is getting dissolved in a particular time. That is rate. So a time will be mentioned in case of a rate. So a particular amount of drug getting dissolved in a particular time. So here dC by dt is directly proportional to the surface area, because more the number of granules, more drug will get dissolved in the GI fluid. Now, divided by volume into height. What is this volume and what is this height? So we can take each granule to describe what is dissolution, the rate of dissolution. We can take each granule. So after the disintegration process, each granule will be covered with a layer of GI fluid. Okay, so each granule will be covered with a layer of GI fluid, and these granules will first get dissolved in each layer, GI fluid layer formed, and after that it will completely get dissolved in the entire GI fluid. This is what is actually happening in dissolution. So here dC by dt is directly proportional to surface area. That means more the number of granules, more will be the surface area, more will be the dissolution rate. Inversely proportional, inversely means like this. Inversely proportional. What is the speciality of inversely proportionality? That means when one side increases, one side will decrease. Okay. So here, when volume of this layer formed increases, when more volume is covered with this granule, it takes more time for that each granule to get dissolved in that particular layer. So when volume increases, the rate of dissolution, that means the time taken for each granule to get dissolved, increases. Height, H means height. That means the thickness of this layer formed. So when thickness increases, volume increases, time taken for dissolution also increases. This is as simple as that. Now, in the CS minus C, what is the CS minus C? CS means this is the concentration of this particular layer formed. And what is this capital C? That means the concentration of the entire GI fluid. So after the granule getting dissolved in this layer, it will completely dissolve in that entire GI fluid. Okay, and this proportionality is changed with a diffusion coefficient. That means the drug getting diffused into that particular layer. So this equation is termed as Noyes-Whitney equation. So this rate of dissolution is governed by Noyes-Whitney equation, which is dC by dt is equal to D into S divided by V into H, the whole into CS minus C. Yeah. Next process is diffusion. So we have completed disintegration, dissolution. So dissolution means it is the process of the solubilizing the drug in the GI fluid. So it is governed by Noyes-Whitney equation. Next is diffusion. So diffusion simply refers to absorption. Okay. It is diffusing across the cell membrane. These three are very, very important in case of an easy diffusion. For a complete diffusion of drug into the bloodstream, it should undergo these three factors. Very important. As a pharmacist, one should know this. This is lipophilic. First, it should be lipophilic, as I've mentioned, for a drug to diffuse across a cell membrane. So our cell membrane is made up of lipid bilayer. For a drug to diffuse across the cell membrane, it should be lipophilic in nature. And next is unionized. What is this unionization? That means without ions. Which are the ions? Cations and anions. So a drug should be free of its ions. Okay. So, and when I take, this is just an example of a drug which is HCl. So, HCl as such, it is in an unionized state, isn't it? No ions on HCl. So, when it splits, it will form H plus and Cl minus ion. That means it will form a cation and an anion. So, if the drug is in this state with charges, it finds difficult to cross a cell membrane because it carries charges, isn't it? It cannot cross the gate easily. So, the drug should be in an unionized state for easy diffusion. So, it should be lipophilic, yes. Second, it should be unionized. That means without charges. It should be in this state. The drug should be in this state for easy absorption or diffusion. Next, it should be non-polar. What is this non-polarity? What is polarity? Polarity means, see, I'll take a simple example. When I dissolve NaCl, salt, in water, I'll tell the salt is dissolved in water, is getting dissolved in water. How? NaCl, to get dissolved in the water, it should form bonds with water molecule. How can it form bonds? It should split into Na plus and Cl minus ion. With these charges, it can easily form bond with the water molecule. This is how a drug is getting dissolved in the water. So if it form ions, and with that ion, if it is forming a bond with water molecule, it is termed as polarity. That drug will be more polar. And what is non-polarity? If the drug is staying in an unionized state without forming ions, it cannot form bonds with water, isn't it? So I can say this is non-polar in nature. Okay, so these are the three important factors for easy diffusion of a drug. So first one is lipophilic. As the cell membrane is made up of lipid bilayer, the drug should be enough lipophilic to cross or diffuse across the cell membrane. Unionized, it should be without charges. Okay. With charges, it find it difficult to cross the gate. Non-polar, it should not form bond with water. Simply as that, it should not be hydrophilic in nature. Next. So keep these three factors in mind. If the drug obeys these three factors, that means if the drug is lipophilic, if the drug is unionized, if the drug is non-polar, I can say it will undergo simple diffusion. Okay, it will get absorbed by this simple diffusion technique. So simple diffusion is the movement of drug from an area of high concentration to the area of low concentration. And it depends on concentration gradient. So when I take a drug, which is the first process, disintegration, second process, dissolution, and third process, it is diffusion. So now, soon after absorption, the drug concentration is more in the site of administration. It can be stomach or intestine. So here, now the drug concentration more in the stomach. So as there is a concentration difference, the drug will try to move to the empty compartment. See, we can just take an example of a train compartment. If one compartment is full and the other one is empty, definitely the people will try to move to the empty compartment, isn't it? The same thing happens here. When one compartment is full of drug concentration, gradually the drug will move to the empty compartment. This is termed as concentration gradient. So why this drug is moving? Because there is a concentration gradient between two compartments. So the driving force of absorption is very important. That is concentration gradient. So in simple diffusion, the drug moves from one concentration to the other, one compartment to the other compartment, and it is completely based on concentration gradient. Now, that is simple diffusion. And similar to the dissolution, here the rate of diffusion is governed by fixed law. So as I've told you, rate means a time will be mentioned. A particular amount of drug is getting diffused in a particular time. So dA by dt, that means particular amount is getting diffused in a particular time is dependent on many factors. So dA by dt is directly proportional to A. The same thing, surface area. More the surface area, more will be the diffusion of drug across the cell membrane. CH minus Cl. That means, as I have mentioned, the movement is completely purely based on concentration gradient. So there should be a higher concentration and there should be a lower concentration. So the concentration of higher compartment minus the lower compartment minus X. That means the thickness of the layer. So it is inversely proportional to the thickness. So here surface area, when surface area is increased, rate of diffusion also increased. When the concentration difference is more, the diffusion rate increased. So it is inversely proportional, this thickness. So when thickness increases, suppose this is the layer, cell layer, when thickness of the layer increases, the diffusion rate decreases. Okay, so this is fixed law, dA by dt. So this proportionality is changed with d or diffusion coefficient. Diffusion coefficient into surface area into concentration difference divided by thickness. So that is fixed law. So dissolution is governed by Noyes-Whitney equation and diffusion is governed by fixed law. Next. Suppose if the drug is lipophilic, unionized and non-polar, it will undergo simple diffusion as I have explained. Suppose if the drug is hydrophilic, if the drug is ionized, if the drug is polar, how can it get absorbed or how can it cross the cell membrane? There comes the facilitated diffusion. That means there are carrier or channels that takes the drug molecule into the cell that facilitate the diffusion. Okay, so there are carriers or the channels that take the drug molecule into the cell, so that facilitate the movement into the cell. So it relies on channel, carrier, and greatly increases the rate of diffusion. So with the help of this channel and carrier, it can easily get diffused into the cell. Now, active transport. What is this active transport? So here, it requires energy. Why there is a need of active transport? See, in case of resistance, I'll just take a simple example in case of resistance, drug resistant. What happens there? When the drug is getting diffused into the, suppose it is normally getting absorbed into or diffused across the cell membrane, and if the cell is not accepting the drug, it will just pull out the drug outside through an efflux pump. Okay, so that is known as active transport. And active transport is the movement of drug from low concentration to high concentration. Very important, because after absorption, when our drug molecule move into the cell, the concentration is more outside the cell and less inside the cell. So if the cell is rejecting that drug, so it is the movement of drug from the low concentration to higher concentration. So without an external energy, how can the drug move from lower to higher concentration? Suppose I need to give pass a ball from the lower side to upper side to my friend. So how will the ball move itself? No. I need to provide an external energy. Either I need to throw the ball or I need to kick the ball, isn't it? So same thing, for a drug to move from lower concentration to higher concentration, we need to provide energy. That is derived from the conversion of ATP to ADP. So when ATP is converted to ADP, a phosphate molecule is liberated, and the liberated phosphate molecule will pull the drug out of the cell. That is active transport. Very important point is that it is the movement of drug from low concentration to high concentration. Endocytosis. Endocytosis is nothing but what the amoeba does. If the drug molecular size is very large, the cell will just engulf the drug into it. So that is endocytosis. Very simple as that. Next, process of absorption is governed by. So there are three factors that governs the absorption. Okay, lipid solubility of the unionized drug. Yes, of course, the drug should be lipophilic. The drug should be in an unionized state. The dissociation constant. What is this dissociation constant? I'll explain in the coming slide. And the pH. pH of the absorption site is very, very, very important in case of absorption. Yeah, we can see each one in detail. Before that, you have to know about the acid base, about the pH and pOH. Now, acid and bases dissociate in a solution and cause a change in the pH of the solution, isn't it? Yes. So normally we formulate the drug as weak acid or weak base. Why? Before that, I'll just explain what is this pH and what is this pOH. So pH is the measure of acidity of a solution, and it gives the concentration of hydrogen or protons in a solution. Lower the pH, more acidic is the solution. Okay. So what is acid and what is base? Acid is a substance that can liberate H plus ions or protons in a solution when dissolved in a solution. When I take HCl, HCl can split into H plus and Cl minus ions, isn't it? So I can say it is an acid because HCl can liberate H plus or protons in a solution. So in order to measure the acidity, you can just measure how much H plus or protons are there in a solution. Simply as that. So to measure the protons or H plus ions in a solution, there is a scale which is known as pH. pH scale. pH is just a scale to measure the amount of H plus ions in a solution. Okay. So there is a relation between pH and H plus ions. pH is inversely proportional to H plus ion. Very important. pH is inversely proportional to H plus ions. So pH is just a scale to measure the H plus ions in a solution. So pH is inversely proportional to H plus ions. So that means what? More H plus ions in a solution, lesser will be the pH value. Okay. That is a measure of acidity of a solution. What is pH? It's a measure of acidity of a solution. It gives the concentration of hydrogen or protons in a solution. Lower the pH, more will be the acidity. Now, before moving to the scale, I'll just explain what is pOH. So here, pOH, similar to the pH scale reading, there is pOH to measure the basicity of a solution. So what was acid? Acids are substances that can liberate H plus ions or protons in a solution. Similarly, what are bases? Bases are substances that can liberate Na plus and OH minus ions in a solution. Or I can say a compound is said to be base if it liberates OH minus ions, OH minus ions or hydroxide ion in a solution. So same like pH and H plus ion, more the hydroxide ion concentration, lesser will be the pOH value because pOH is inversely proportional to the OH ions. Greater the OH, lesser the pOH value. Okay, lesser the pOH, greater will be the basicity. Okay. So pOH and pH are just a scale to measure the acidity and basicity. So pOH measures the basicity of a solution and gives the concentration of hydroxide ion in a solution. Lower the pOH, more the basic the solution. So these pH and pOH are just a scale to measure the basicity. So yeah, it is given here. It is pOH and pH. This is for base and this is for acid. So what is the relation? pH inversely proportional to H plus ion. Listen carefully. If a compound liberates more H plus ions in a solution, it is more acidic. More H plus ion, lesser the pH value. So this is the scale of pH. It reads from 0 to 14. The lesser value, that means 7 is neutral. For both the scales, 7 is neutral. And below 7, 0 to 7 indicates it is an acid. Above 7, it indicates it is a base or less acidic. Now, POH, similarly, POH is inversely proportional to OH minus ions, okay, hydroxide ion. So, more hydroxide ion in a solution, lesser will be the POH value, more will be the basicity. So, lesser, that means 7 to 0. In this scale, lower value indicates it is more basic. And the higher value, that means more than 7 indicates it is less basic in nature. So that is about pH and POH. Okay. Now, for a drug to be in an unionized state, it should be either a weak acid or a weak base. Because stronger the acid, that means what? When I take HCl, okay, when I take HCl, more H plus ions means lesser the pH value, isn't it? When higher, when the H per hydrogen ion concentration go higher, the pH scale reading will go down. Okay, so more H plus ions liberated, lesser will be the pH value, more will be the acidity. So here, when we formulate a drug as a strong acid or a strong base, what is the result there? Stronger the acid, stronger the base, more will be the ionization. It will split into its ions easily. Okay, so as I've mentioned before, for a drug to easily get absorbed, it should be in an unionized state. Don't forget that, unionized state. So when I take a drug, it should be in a weak acid or a weak basic state to lesser the ionization. Very important point. Okay, yes. Now, this ionization is given by a Ka, that means dissociation constant. It can be an acid dissociation constant as well as a base dissociation constant. So Ka means it is an acid dissociation constant. So when we formulate a drug, in order to check the absorption pattern, we should know about the dissociation constant, that is Ka or either Kb. If it is an acid, if the drug is a weak acid, we should know about the Ka value, and if the drug is a weak base, we should know about the Kb value. So Ka is equal to, okay, I can say it is a dissociation constant. Dissociation constant, that means the process of dissociating, process of an acid getting dissociating into its ions. So similar to pH and H plus ion, here also there is a scale to measure Ka value. It is known as pKa. pKa. So pK is a scale to measure the Ka value. More the Ka, lesser the pKa. That means stronger will be the acid. So more the Ka means more will be the dissociation of the given acid. So more the Ka, lesser will be the pKa value. So we need a lesser Ka value for easy diffusion to decrease the ionization. Okay. So Ka is equal to, there is an equation when I take HCl, Ka is equal to the concentration of H plus into the concentration of Cl minus ion divided by the concentration of HCl. This is the equation. Okay. Similarly, to measure the dissociation of a base, see again I'm telling, we need the drug in an unionized state. It should not undergo dissociation. Or if it is undergoing, it should undergo only like 10% or a 20% and drug should get dissociated. Now, the base dissociation constant, Kb. It is the measure of the drug, weak basic drug that get dissociated. So Kb is, when I take NaOH as a drug, basic drug, is equal to Na plus into OH minus divided by NaOH. This is the equation. So same like pKa, pKb is inversely proportional to Kb. So pKb is also a scale to measure the dissociation constant, how much the acid or like the base is getting dissociated. More the dissociation, that means stronger will be the base. Okay, so we need a lesser Kb value. So more the Kb value, lesser will be the pKb value. That indicates stronger the base. Yeah. So pKb is a negative log of Kb, negative log of Kb. So while changing this proportionality sign, you will get pKb is equal to negative log of Kb. Next, yeah. From and one more thing I left out. Very important. The basic functional group will have a greater degree of ionization when the pH is less than pKa, and a lower degree of ionization when the pH is greater than pKa. Okay, that means when we formulate a drug as a weak acid, this is the thing which you should like by heart, and you should be thorough with this. Okay, so when we formulate a drug as a weak acid, when it reaches the acidic medium, it will stay as unionized. So yeah, we need an unionization, isn't it? So greater will be the absorption. So in our GI tract, which is the acidic medium, it is the stomach, isn't it? So here, when I formulate the drug as a weak acid, when it reaches the stomach, it will get absorbed. Okay, so when I give the drug in a weak acidic form, when it reaches the acidic medium, it stays in an unionized form, so greater will be the absorption. So it is absorbed greater in the stomach. Now, in case of weak base, same thing. Weak base in basic medium, it will be unionized, and greater will be the absorption. So which is the basic medium in the GI tract? It is intestine. Okay, so weak base, when it reaches the basic medium, greater will be the absorption, because base in basic medium, it will be unionized, so greater will be the absorption. Acid in acidic medium remains unionized, greater will be the absorption. Where is the acidic medium? Stomach. Where is the basic medium? It is the intestine. So, but if when we give a weak acid, when it reaches the basic medium, what happens there? It will be ionized. It will split into its ions. So more will be the excretion. As I've mentioned, when a drug ionizes, HCl ionizes, it will form water bonds easily. It will form bonds with water molecule easily, and that get excreted more. So when I give a weak acid drug in basic medium, when we change that medium to basic, the ionization will be more, greater will be the excretion. And similarly, when I give a weak basic drug in acidic medium, greater will be the ionization, more will be the excretion. Okay. So what about the basic, when the drug is a basic drug, okay, weak basic drug, it should reach the intestine, isn't it, to get readily absorbed. Okay, so it should bypass the stomach to reach the intestine. Here comes the use of entry coated. When we give an entry coating to a tablet, what happens there? It is protected from the GI fluid, because as it is a weak acid, to get readily absorbed, it should safely reach the intestine without getting ionized, because as it is a basic drug, when it reaches the acidic medium, that is the stomach, it will split into its ions. So you have to protect the basic drug by giving an entry coating so that it can easily reach the intestine, and there it is getting readily absorbed. So that is the thing. A basic functional group will have, now you can understand, a basic functional, that means a weak basic drug will have a greater degree of ionization, will split into its ions when it reaches the acidic medium. That means when the pH is less. And lower degree of ionization when the pH is greater. That means in the basic medium. Now, when the drug is a weak acid, it will have a greater degree of ionization when the pH is greater. Okay, when the drug is a weak acid, when it reaches the basic medium, it will split into its ions. Lesser will be the absorption. Yeah. Next. So that is about the absorption. Next, we'll go to distribution. What is this distribution? So first was the absorption parameter. Absorption was the movement of drug from the site of administration to the bloodstream. Now the drug concentration is more in the plasma, or I can say in the bloodstream. So after the absorption, the drug concentration is more now in the plasma. So as I've mentioned, the drug will move based on the concentration gradient, isn't it? If one compartment is empty, definitely the drug will move to that empty compartment. So that causes this distribution. As after absorption, after the complete process of all the Ds, the drug concentration is more in the plasma. So gradually the drug will move to the tissues or site of action. And that movement is reversible because it should come back to the bloodstream to get excreted out. Okay, yes, that is distribution. So when the drug is filled inside the plasma, due to the concentration difference, it will move to the tissues. Drug distribution is how rapid and to what extent the drug in the plasma gets taken up by the tissues. Challenging to measure the tissue concentration, plasma concentration measures how much the amount of drug is getting distributed. That means to measure how much amount of drug is getting distributed, we cannot collect the blood samples from the tissues, isn't it? So we can easily collect the blood sample. If the concentration of the drug in the plasma or the blood is less, that means what? More drug is getting distributed. So this is given by a term or defined by a term which is known as volume of distribution. Volume of distribution. What is this volume of distribution? See, the volume is not the ml or liter. It is not a physiological volume like that. So it is just the amount of how much, it is the measure of the drug concentration reaching the site of action or the tissue level from the bloodstream. Okay. So volume of distribution is the primary distribution parameter of the drug. How much amount of drug goes from the bloodstream to the site of action. So VD has a unit of volume, but it is not a physiological volume. It is not expressed as ml or a liter. So VD reflects how a drug will diffuse throughout the body. That means if the drug is highly lipophilic, like it is non-polar, or if it is unionized, the volume of distribution will be more. That means more drugs can easily diffuse through the cell membrane and that can reach the tissue or the site of action. So in that case, the volume of distribution will be more. Okay, yes. So volume of distribution is given by an equation. VD is equal to AB by CP. That means amount of drug divided by plasma concentration. So when the plasma concentration, see, this is also inversely proportional, isn't it? When the amount of drug in the plasma concentration decreases, volume of distribution increases. That means only less amount of drug is still inside the plasma. More drugs are getting distributed into the tissues. So see, AB is directly proportional to VD. That means when the amount of drug inside the body increases, volume, that means more amount of drug is getting distributed. When I take, suppose, 10 milligram of a drug, just an example, okay? When I take 10 milligram of a drug and I'm collecting the blood sample to check the volume of distribution. Suppose I'm getting 2 milligram. That means what? 8 milligram is there inside the body. That means 8 milligram got distributed. So when the amount of drug inside the body increases, the volume of distribution increases. And when the plasma concentration decreases, that also means the volume of the distribution increases. So this is a biopharmaceutic value or the term for distribution, volume of distribution. Now, yeah, I've made a simple calculation for you. Theophylline has a volume of distribution. Theophylline has a volume of distribution. Yes. Volume of distribution is given as 0.5. See, the units are very, very important. It is liter per kilogram. 0.5 liter for 1 kilogram. And the patient is 70 kilogram. The weight is 70 kilogram. Plasma concentration is also given. 12 milligram per liter. How much theophylline is in their body? So what we need to find out? Very simple, direct question. We need to find out the amount of drug. So you know the equation. VD is equal to AB by CP. So we need to find out the AB. For this, AB is equal to CP into VD. So what is the CP, plasma concentration? Yeah, it is given 12. Okay. So what is volume of distribution given? Don't make a mistake here because it is given as 0.5 liter per kilogram. It is for 1 kg, but the patient weight is 70 kilogram. So you have to multiply that also. So you will get a value as 420 milligram. So in case of calculation will be very, very simple if you know the equation. Yeah. So now causes of apparent volume of distribution. See, now what is distribution? It is the movement of drug from the bloodstream to the tissues or the organs. Okay. So if the drug shows a low volume of distribution, that means what? Only less amount of drug is reaching the site of action. That means what? See, either it will be a large drug granule, hydrophilic, plasma protein bound, and impermeable membrane. If the drug molecule or drug granules are larger in size, it finds it difficult to diffuse across a cell membrane, isn't it? And to reach the tissue. So if the drug is having a large size, molecular size, volume of distribution decreases. If it is hydrophilic, I have already explained this. If it is hydrophilic, it cannot easily cross the cell membrane, which is highly lipophilic. Next, about plasma protein. There are proteins inside the plasma. Okay. There are proteins inside the plasma like albumin, globulin, alpha aminoglycoproteins are all the proteins present inside the plasma. So some drugs like for example, I'll take sulfur drugs. Sulfur drugs are more plasma protein bound. So when I take a sulfur drug, when it reaches the plasma or the bloodstream, as it is having more affinity to the plasma protein, it will bind to this protein and it will be in a complex state. So what happens there? The molecular weight increases. The size of the drug increases there. So as the size increases, the diffusion decreases. And what happens to the volume of distribution? Volume of distribution decreases. So if the drug is having high affinity to the plasma proteins, the volume of the diffusion will decrease, the volume of distribution also decreases. And in case of an impermeable membrane, if the drug, if the membrane is not permitting the drug to diffuse across, what happens there? The drug will not get absorbed. There, the volume of distribution decreases. Now, the opposite thing. If the drug is having a high volume of distribution, that means more amount of drug are reaching the site of action, isn't it? So the drug, if the drug granule size is very small, it can easily diffuse through the cell membrane and reach the site of action. When it is hydrophobic, what is this hydrophobic means? Hydrophobic means opposite to hydrophilic. That means water hating, or I can say it is lipophilic. When it is lipophilic, it can readily cross or diffuse across the cell membrane. Tissue protein. Similar to the plasma protein, there are tissue proteins which are present on the tissues or the organs. So some drugs are more tissue protein bound rather than the plasma proteins. So in that case, they will readily enter or readily diffuse into the site of action and they will stick on to this tissue proteins. So in that case, more drugs will reach the site of action. I can say higher the volume of distribution. Now, if the cell membrane is permeable, that means it allows more drug to enter the body. That means higher volume of distribution. Yeah, so that is the thing. Next comes, yeah, as I've mentioned, protein binding. There are plasma proteins as well as tissue proteins. Some drugs are more bound or have more affinity to the plasma proteins. Some drugs show more affinity to the tissue proteins. So if the drug is more having more affinity to the plasma protein, it is getting excreted readily, isn't it? It will move along with the bloodstream. Suppose if the drug is having a higher tissue protein binding capacity, it will readily move into the tissues and there is a chance of getting accumulated. So in that case, excretion is a slower process. So that is this plasma protein binding. Next comes the half-life. What is this half-life? So half-life is nothing but the time taken for a drug to reduce to half of its initial concentration. That means when I give a drug of 100 milligram, I'll take a simple example so that I can easily calculate. 100 milligram, the time taken to reduce to 50 milligram, half, correct? Half of its initial concentration is known as T half or half-life. Okay, half-life is the time taken for a drug to reduce to half of its initial concentration. Now, for a drug to completely get excreted from the body, okay, it takes almost 5 T half. That means in the first T half, the drug reduced to 50. Okay. Drug reduced to 50%. That means 0.5 got excreted out. In the second T half, 25. That means a difference of 75% got excreted. The next T half, that is 12.5, almost 87 got excreted out. The next T half, it is 6.25. See, almost 93% got excreted out. In the fifth T half, almost 97% of the drug got excreted. So the drug, almost 97% of the drug get excreted after the fifth T half. So that is half-life. Next is the metabolism. What is this metabolism? So absorption is over, distribution is over. Next factor is metabolism. So metabolism means, now you can clearly understand what is this lipophilic to hydrophilic state. Okay, so as I've mentioned, the drug for like easy diffusion, it should be lipophilic in nature. Okay, so for excretion, it should be hydrophilic in nature so that it can easily get dissolved in the urine. So the metabolism is nothing but the conversion of lipophilic drug to hydrophilic drug, or it is the conversion of active form. Active form means if it is lipophilic in nature, it is readily active. It can readily cross the cell membrane and get easily absorbed. So it is the conversion of active form to inactive form, or it is the conversion of lipophilic drug to hydrophilic drug. That is simply the metabolism. So metabolism, the other name is biotransformation. Biotransformation. So there are two phases for metabolism. This metabolism normally happens in the liver. Okay. So suppose if that drug is like slightly lipophilic and slightly hydrophilic, while undergoing the phase 1 metabolic reaction, it is just converted to hydrophilic and that can readily get excreted in the urine. But if it is highly lipophilic, if the drug is highly lipophilic, it should undergo, after phase 1, it should undergo phase 2, that is conjugation reaction, to get converted to hydrophilic. Now, what is this functionalization and what is this conjugation reaction? So if a drug is hydrophilic, it will first, if the drug is lipophilic, after distribution for excretion, it will first undergo phase 1 metabolic reaction, that is known as functionalization reaction. So there are 3 types of functionalization reaction: oxidation, reduction, and hydrolysis. Oxidation, reduction, and hydrolysis. So oxidation is addition of oxygen, reduction is the removal of oxygen, hydrolysis is nothing but the reaction with water. So still, if the drug is lipophilic, even after completing this functionalization or phase 1 metabolic reaction, it will move on to phase 2 conjugation reaction. So in conjugation, there are different types of conjugation. What is actually conjugation? Here, the lipophilic drug is conjugated with a polar moiety. A bigger polar group is conjugated to the drug. So anyway, definitely the drug will convert to the hydrophilic form. Okay, that is conjugation. So the type of conjugation is based on the conjugate we are adding to the drug. Okay, it can be sulfation, it can be glucuronidation, acylation. It is purely based on the type of conjugate we are adding to the drug. So after conjugation, it will it will convert to hydrophilic form and that get excreted out. So that is functionalization and conjugation reaction. So phase 1 functionalization reaction, there is reduction, oxidation, and hydrolysis. Phase 2 conjugation reaction, phase 1 functionalization reaction and phase 2 conjugation reaction. Here the drug is conjugated with either glucuronic acid, sulfuric acid, acetic acid, amino acid, and it is converted to a polar group. So it is converted to hydrophilic form that can readily get excreted out. Next, you should know about enzyme inducers and enzyme inhibitors. What is this enzyme inducers and enzyme inhibitors? Even if it is a functionalization reaction or it is a conjugation reaction, you need enzymes for a reaction to take place. So the very common enzyme that helps in metabolism is CYP enzyme, cytochrome P450 enzyme. Okay, cytochrome P450 enzyme. So there are drugs that induce the effect of this enzyme, and there are drugs that inhibit the effect of this enzyme. Okay, suppose I'm giving a drug and now it is going, after distribution, after showing the effect, it is now going to get metabolized with the help of an enzyme, cytochrome P450. Okay. So, and along with this drug, suppose if a patient is taking warfarin, I'll just take an example of warfarin, which is a very common anticoagulant drug. Commonly, the patients take this warfarin. So if a patient is on warfarin and suddenly he got tuberculosis, he's affected with tuberculosis. So a doctor prescribed rifampin there. Doctor prescribed rifampin, the drug rifampin. So the patient started taking rifampin. And after some time, after some days, the patient is complaining that the blood is still clotting. Okay? Because of the effect of rifampin. Because rifampin is an inducer of the CYP enzyme. That means this rifampin will induce the effect of the CYP enzyme. So more CYP 450 is getting activated, more warfarin is getting metabolized. So before showing the effect, it's just getting metabolized and getting excreted out. So this is the effect of an inducer. So when a drug is given, the drug needs a CYP enzyme to get metabolized. Either a functionalization or a conjugation, the drug needs a CYP enzyme to get converted to a hydrophilic form. So if the patient is on a drug and suddenly if the patient takes any one, these are the examples of inducers. So any one of this drug, inducer drug, this drug will induce the enzyme activity. So more enzyme is getting activated. So more warfarin is converted to its metabolite. So what happens there? Decrease in the effect of the drug. Now, there are inhibitors. So when I give, say, I'll take warfarin. If a patient is on warfarin, it is normally metabolized by CYP450 enzyme. So if the patient is having some fungal infection and the doctor prescribed ketoconazole. So here ketoconazole is an inhibitor of this enzyme. So when we give ketoconazole, the ketoconazole will inhibit this CYP enzyme. Will the warfarin get metabolized? No, the warfarin will not get metabolized. It will cause accumulation and toxic effect. So when a drug is prescribed with an inhibitor, it will decrease the metabolism of that drug and it can cause toxic effect. It will cause accumulation and toxic effect. Now about excretion. The last thing is excretion. So excretion is nothing but just the removal of drug from the body. It can be either through the urine, bile, sweat, tears, milk or stool, whatever it is. It is after the metabolism. After the metabolism, the drug is converted to hydrophilic form. Now it is ready for excretion. It is just the movement of drug or excretion of drug through the urine or whatever it is. So the excretion normally happens through the kidney, isn't it? Kidney. Renal excretion. So in renal excretion, which are the functional unit of kidney? They are nephrons, isn't it? So there are different parts for nephron. One is filter, glomerular filter. This is proximal convoluted tubule. This is distal convoluted tubule, and this is collecting duct. Okay, so there are many processes for the final formation of urine. So normally the whole blood from the body will get filtered through this glomerular filter, and after the filtration is the secretion step. Okay, where the waste products and the other parts are getting secreted into the proximal convoluted tubule. Next comes the reabsorption. The reabsorption normally happens in the distal convoluted tubule and some part of collecting duct. Reabsorption means some drugs or some vitamins or minerals are getting reabsorbed back into the blood through this distal convoluted tubule. And at the end, it is getting excreted through this collecting duct. So this is the process. These are the four processes for renal excretion. Next is clearance. What is this clearance? What is the difference between clearance and excretion? So excretion means I will define the excretion as it is a complete process through the whole blood. Okay, the whole blood is filtered through these nephrons and the drug is excreted from that. The difference between clearance and excretion is that in clearance, it is the excretion of drug or clearance of a drug from a particular volume of plasma, a particular amount of drug in a particular time. That is clearance. So clearance is done by two main organs. One is liver and the other one is kidney. So you all know the blood is circulated throughout the organs, like even the liver or the kidney. So when blood is circulated through this organ, either the liver or the kidney will extract some volume of plasma. Suppose it can be a 10 ml. So some amount or some volume of blood is extracted into the liver or the kidney, and the liver will process that, and from that particular amount of plasma, some amount of drug is getting excreted in a particular time. That is known as clearance. Okay, yes. So total clearance means it is the total process of the kidney as well as the liver. Large clearance, that means if large volume of blood is taken up by the liver and the kidney and large amount of drug is getting cleared off, that means what will be the volume of distribution? Like the drug is getting cleared in a larger volume from the blood. That means only small amount of drug is reaching the site of action, isn't it? Small will be the volume of distribution and rapid will be the elimination, because a large volume is getting cleared off, isn't it? Large clearance. And what about the short, like half-life? It is very short half-life. That means it takes only very short time to convert from the initial concentration to the half of its initial concentration. Okay. Now, small clearance. Small clearance means only small amount of drug is getting extracted by the liver or the kidney, and only small amount of drug is getting excreted through the urine. That means what? large volume of drug is reaching the site of action. Okay, rather than staying inside the plasma, it is moving into the site of action. So large will be the volume of distribution, and the elimination will be very slow. Okay, because most of the drug are there inside the body. And long half-life, the half-life will be long. It takes time for a drug to come back to the bloodstream and to get excreted out. So that is clearance, the difference between clearance and excretion. Now, clearance, there is an equation for clearance. Clearance is equal to Vd into K. Or I can rewrite this equation. K means elimination rate constant. Elimination rate constant is equal to Cl by volume of distribution. So based on the first order reaction, what is T half? T half is equal to, based on first order, T half is equal to 0.693 divided by K. Now, you can rearrange this K, rewrite this K. T half is equal to 0.693 divided by Cl. The Vd will come here, Vd. So what is clearance based on first order reaction? So clearance is equal to 0.693. You can take this T half down. So 0.693 into Vd divided by T half. So this is the equation for clearance, the basic equation for clearance. There are many equations for clearance. This is one among the equations. Next, the last process is elimination. So I've told you the last thing is excretion. So what is this elimination? What is the difference between excretion and elimination? So in excretion means it is just the removal of drug from the body. It is just, the body is just excreting the drug out. Okay. So elimination means it is the combination of liver metabolism and renal excretion. Here comes the difference. Elimination include both metabolism and excretion. So why the metabolism is added under this elimination process? Because what was metabolism? Metabolism is simply the conversion, or I can say metabolism is helping the drug to get excreted out, isn't it? It is also a process of elements, excretion. So metabolism means, or biotransformation means, it is the conversion of lipophilic drug to hydrophilic. So it is helping the drug to convert to hydrophilic, and that get readily dissolved in the urine, will get excreted out. So this liver metabolism and renal excretion, after metabolism in the liver, it is converted to it is excreted through the kidney. So both this metabolism and renal excretion comes under this elimination process. So elimination, all process involved in the removal of parent drug from the body. It involves all the process, either like both metabolism as well as excretion. Yeah. So thank you. This is the end of this small portion from pharmacokinetics and biopharmaceutics. So this is what is a brief note on ADME, that is absorption, distribution, metabolism, excretion, and some add-on topics like clearance and elimination. So I think, I think this session was clear to you. And thank you all for your valuable time. So we'll definitely see you in the next session. So stay tuned. Thank you.